Good evening, everyone. We welcome you all to OrthoTV. We are live now and we hand over the proceedings to Dr. Kiran Kharat, convener of the session.
Thank you very much, Neeraj and OrthoTV and Ashok Shah. I welcome all of you to the 15th session in the conclave. And I realize that it is called the Basic Hip Conclave, but now, as we have come to the 15th session, we are dealing with complex topics. And today's topic is pelvic discontinuity. And it is helmed by Dr. Nikhil Shah, who has huge experience and knowledge in pelvic discontinuity. We have our able panel in the form of Dr. Vikas, Kulshrestha, Dr. Gurinder Bedi. We're waiting for Narinder to join, and my co-convenor, Dr. Surendra Patil, with me. So this platform is very valuable because there are no time constraints and we can really immerse ourselves in a topic and glean valuable insights. Needless to say, to reach this level of handling such cases independently takes thousands of hours of learning and assisting and reading. And if such a case comes into my practice, I will not hesitate to involve friends and colleagues who are adept at pelvic acetabular work. For instance, in Pune, I'm fortunate to have Dr. Mahesh Kulkarni as my friend, who also has been trained in the UK and does pelvic acetabular work. So I think if such cases come, these talks help us to get insights as well as to know that we have certain limitations and we have to respect that and then ask for help, which is very, very crucial. In pelvic discontinuity, the overall aim is stability and it's not precise reconstruction because these cases are often old. And the overall aim is to support the acetabular component, and that should give a stable base on which you can do the implantation. Sometimes these are very complex, and I'm sure Nikhil has got a huge bank of cases. Sometimes one may have to do ischial osteotomy to derotate and mobilize the non-union. And therefore, proper consent counseling is required. And obviously, all the implants and all the instruments should be at hand. I think it's very important to mention that there is a risk of potential uncontrollable bleeding in these surgeries, and a vascular surgeon standby is vital with proper preoperative CT angiography and anticipation. Nikhil has also written a chapter in Professor Rajesh Malhotra's book, and that is well worth reading. I'm sure he will, discuss in detail like how to fix, how to ream, how to graft, and how to implant. And I will hand over to Dr. Nikhil Shah from the UK. Welcome, Nikhil.
Thank you, Kiran. Good evening, everyone. Can you see the screen?
Yes, we can.
Yeah, you can see?
Yes.
Great, thank you. So once again, it's a pleasure to be part of the conclave. The last 15 sessions have been wonderful. I've learned so much from the faculty that has presented. So in this talk, what I will try and do is share with you my experience on how I got into pelvic discontinuity management, what my learning curve was, some of the complications I've had along the way, and where we are up to now. So we'll cover what is pelvic discontinuity, starting right from the basics, how to assess it, and how to anticipate what the problems might be, the principles of management, and then using some illustrative cases, we will try and look at the different philosophies that are available in treating it. I'm not going to discuss the theoretical aspects of the results and the literature review because that is available in the books and in the journals. And I'm sure that that can be read by the interested people. So for me, pelvic discontinuity is when the top half of the innominate bone or the pelvis that forms the acetabulum is separate from the lower half of the acetabulum, either because of a fracture or because of bone loss. Generally, there is massive bone loss. There can be infection, or there can be a fracture or mechanical abrasion by the components. What happens is the anterior column and the posterior column of the acetabulum becomes non-supportive. So you cannot put a standard component inside a discontinuity and expect it to be stable. When it is chronic, we call it pelvic discontinuity. So this has happened over a period of a few months or sometimes years. There is a bone loss in the acetabulum. There may be a gap between the columns, and it's a slow process where the cup starts migrating into the pelvis and destroys the columns. Or it can be an acute discontinuity, which is a periprosthetic fracture. This can be either post-operative because of trauma, or it can be intraoperative because of reaming or because of attempted impaction of the uncemented cup and similar mechanisms. If you look at the historical literature on periprosthetic fractures, if the fracture was undisplaced, noticed during surgery, and treated with, let's say, a cup with screws with conservative treatment, majority of the times, the fracture did heal. But the cup eventually became loose in quite a few cases and increased the rate of revisions. For displaced fractures, plating was recommended historically in most of the literature, but unfortunately, they don't give the long-term results of the philosophy. In terms of chronic discontinuity also, many different solutions have been tried. So people have tried cemented cups, uncemented cups, and jumbo cups. They've tried bulk allograft or total acetabular allograft. People have tried fixing the columns with plates and screws or using reinforcement cages or total acetabular allografts to try and gain some stability. And more recently, the cup cage construct. Again, for many of these philosophies, there is not much long-term data available. And it's difficult to make a selection as to what exactly to do out of the various different philosophies or strategies that are available. My experience with reinforcement cages, unfortunately, has not been that good. I've never done these myself, but the few that I've come into contact with have been those that have been attempted elsewhere and unfortunately failed. And the failure can be because of infections or dislocations. The cup can break, loosen, or migrate. So if you think of it biomechanically, using a reinforcement cage is like using an internal plate on the concave surface of the bone and trying to fix the discontinuity from the inside. Whereas when you fix an acetabulum using posterior column plating, you're fixing it on the tension band surface. And biomechanically, a cage can never give fixation that is as good as proper column fixation. So when I started doing my revision work in 2006, and I started getting these discontinuities, I thought a lot about what exactly is the problem. Is it just a big hole that you have to fill with something in a revision hip, or is it more of an acetabular non-union? So for a fracture surgeon who does pelviacetabular work, this is a transverse fracture. And the way we treat it is you derotate the columns, you reduce the fracture, and then you fix it either anteriorly or posteriorly using column plates or screws. So for me, a discontinuity is like an acetabulum fracture. It's a non-union of a fracture where the socket is loose and there is a lot of bone loss. If you approach it from this philosophy, then the treatment principles become quite clear. Let's look at how we can assess discontinuity. One of the important things is to have a high index of suspicion. And again, if we borrow the principles of how we assess an acetabulum fracture using the iliopectineal line, the ilioischial line, your teardrop, and all the other bony landmarks that you see in a normal pelvic X-ray, and then you apply that to your revision surgery. So often discontinuities are missed on the AP X-ray. One reason is because they are not very easy to spot if they're undisplaced on the AP X-ray. And second reason is people don't anticipate that there might be a discontinuity whenever there is extensive bone loss. So if you get Jude views, you can always see that the fracture line has gone through the anterior column and through the posterior column on the Jude views, which confirms that this is a discontinuity. And then you can have your strategy ready before surgery of how you're going to deal with this. CT scans are very helpful to delineate exactly how much bone stock is present, what's happening to the anterior and the posterior column. And you can perform 3D reconstructions of the CT scans using these transparent type of sequences, which gives you a very good idea of where the screws are sitting. And if you put contrast, you can also get a good idea about what the blood vessels are doing adjacent to the screws. And nowadays, for difficult cases, you can do 3D printing of discontinuities and actually do a dry run of the surgery on a model and make sure that your strategy is going to work. So if you think of it like a non-union, how do you treat a discontinuity? Let's break up the problems into simple problems which we can solve one at a time. So because there's a fracture non-union, how do you treat a fracture non-union? You fix it stably using plates and screws. So the first principle is to fix the columns and to convert a discontinuity into a continuity. What was the second problem? The second problem was that there was bone missing in the discontinuity. So you give back bone. And from the past lectures, I'm sure you've seen a lot of cases that I've shown. I'm a big fan of intraction bone grafting and structural bone grafting. So you give bone back to restore the biology. And the third thing then is once you have done these two, you can implant the socket. In most cases, if you can get stable fixation and sufficiently good bone grafting, you can do it in one stage. In some cases, which I'll show, it's not possible to get all of that done in a single stage. And when I began treating these discontinuity cases, my first few cases, I have done it in 2 stages. So let's look at some illustrative cases to show these points. So this was the very first case that I treated in 2006. She had a very long follow-up of a Charnley cemented total hip replacement, but unfortunately, no X-rays were available in the last few years. And her presentation was actually with a dislocation. And when the dislocation was being reduced, we picked up the fact that the cup is loose and she has an impending discontinuity. Unfortunately, she had another dislocation, and this time the discontinuity became completely displaced. And you can see that the socket has also migrated and come out of the acetabulum, and there is an obvious discontinuity on the CT scans. This was my very first case. And as a young surgeon, I didn't really have a great deal of experience in managing these problems. So I dealt with it like an acetabular non-union by taking all the components out, performing a girdle stone excision, and then fixing the discontinuity with a double plate and with bone grafts. To my surprise, it healed. It healed so well that we decided to do a second stage. And then we put a hip replacement in with some more impaction bone grafting. And she did quite well. So that X-ray was taken around 8 years. She will reach 14 years of follow-up this year. Our follow-ups have become a little bit chaotic because of the COVID-19 crisis. So I'm sure she'll come back next year for an up-to-date X-ray. And you can see that the discontinuity has healed. This was the second case, which a colleague was doing in a different hospital. And he gave me a ring that during surgery, he has discovered pelvic discontinuity and he wasn't comfortable managing it. So we asked him to just leave it like a pseudo in the first stage without doing anything. You can see, unfortunately, the trochanter was also quite crumbly and it fractured. So in the second stage, we fixed it with plates and screws and put some bone grafting. The bone quality was really, really poor. And I wasn't at all confident that I can complete this operation and perform a hip replacement. So I did it in stages. And once it had healed, in the third stage, some more bone grafting and a discontinuity reconstruction. And again, this patient is reaching about 12 or 13 years now. This was another case where there was a discontinuity and the cup had started migrating into the pelvis along with some cement. I think it was a dual mobility type of cup, which had been done for a metal on metal revision. So it started with a metal on metal failure and the surgeon tried to revise it, but the columns were unsupportive and very rapidly it failed with discontinuity. So in this case where the cement and the cup is migrating into the pelvis, it is prudent to get a CT angiogram done to make sure you know exactly where the blood vessels are, where the cup is sitting. If there are screws inside the cup, that is important. And then to warn your vascular surgeon who can be available during the surgery if required. In this case, we took the cup out safely through the hip joint itself without needing to go into the pelvis. But there are some tricks that you learn when you do pelvic surgery. You can put your finger on the quadrilateral plate using a Cocker-Langenbeck approach, and you can actually palpate the cup on the inside and gently mobilize it with your digit. And then you can take it out safely. And that's the first stage done with column fixation and bone grafting. And that's the second stage with a trabecular metal shell and augments. So my first few cases I did with cement. And then once TM became available in the hospital, for many of these cases, I shifted to trabecular metal components, which has really good ingrowth properties. So another case which a colleague had done, he had revised the hip, and on the post-operative X-ray, he realized that there was a discontinuity. Now, whether this was intraoperative or preoperative, we could not tell, but this was an uncemented cup which had started migrating out because of the discontinuity. And we did this in a single stage using column fixation, impaction bone grafting, and for the superior defect, an augment. And you can see the follow-up X-ray. So even in one stage discontinuity, a cemented cup can work quite well, but not in all of them. So there are specific areas where a cemented cup will not work in these cases, and you have to be aware of that. This was a case on the right side. This lady had unfortunately had 4 revisions in a period of 5 months, and unfortunately all of them had failed. The last one was a failed cage with a cemented cup, and she was clearly infected, and she had had multiple operations. So we decided to just take everything out. But look at the left hip. So this is important because of what's going to come. So I took everything out on the right side. I fixed the discontinuity, and there was a lot of discussion whether or not metal work should be put inside a hip that is obviously infected. But at that time, I felt that a stable, well-debrided hip with a fixed discontinuity is better than an unstable discontinuity in the presence of infection. She did quite well with the right side and decided she did not want any further revision on the right side, and she was happy to live with a girdle stone. But the left side, the cup started migrating and she developed a discontinuity. And that's the left side. You can see how poor the bone stock is. On the CT scans, axial image, you can see that barely any columns are left, and really there is very poor bone stock to attempt any reconstruction. So I did this again in a single stage with a plate, bone grafting, and with a cup, and she did quite well. She had 1 or 2 dislocations, but apart from that, she was fine and did well for up to 8 years. And then unfortunately, even the left side got infected as a complication. So I took everything out as a pseudo, and then sadly, later on, she passed away because of some other reasons. So this I have counted as one of the failures in my series. This was a late failure due to infection. Let's look at some acute pelvic discontinuity cases. These are periprosthetic fractures. The first one is a metal-on-metal hip with the chorial and the ASR, which fractured after a minor fall. And she had pain in the hip for 2 years before that. So it could have been an insufficiency fracture leading to a discontinuity. During surgery, there was an obvious discontinuity. The cup came out. The stem was very well fixed, and this was a chorial stem. So I retained it. I fixed the fracture like a transverse fracture with impaction bone grafting, and then reconstructed it with a trabecular metal cup. And these cups can take cemented liners, and a double plate gives you much better rotational stability. So using a Cocker-Langenbeck approach, you fix the columns with 2 plates. And I was pretty happy with the reconstruction, but unfortunately, she dislocated on the 9th post-operative day and developed recurrent dislocation. So then I went in and changed the stem, after which she stopped dislocating. This X-ray was taken at 8 years, where she was walking with a single stick with a slight limp. Her follow-up will soon reach 13 years. This was another case that was after trauma, an uncemented cup with a displaced acetabulum fracture, periprosthetic, which is like an acute discontinuity. Again, this was revised in a single stage with 2 plates and a trabecular metal cup. And this was a recovery X-ray where she was dislocated. After changing the stem, she stabilized, and she will also reach 12 to 13 years soon. So from some of the earlier cases I did, I realized that dislocation was a problem in these cases. And if you look at the literature review for discontinuity, all of that will point towards a very high risk of dislocation. Dislocations are more in revisions anyway, between 15 to 20%, and in discontinuity revisions, they're even higher. So we thought a lot about why this might be. Because of multiple previous operations, patients have got poor soft tissues, they're non-ambulatory for a long period of time. And then the only thing that I was not doing was I was not revising the stem. And we know that isolated component revisions have got a higher risk of dislocation. So based on the early learning experience, I developed a fairly low threshold for revising the stem if required. to get a more stable hip. And once I started doing that, the problem reduced significantly. So this was a case where the discontinuity had been treated by someone else using a cage. It was an intraoperative diagnosis, and all they had at that time was this kind of cage. But unfortunately, as happens with most cages, they cannot provide sufficient stability to the discontinuity because of an internal plate. And you can see the cage has not only broken, but also started migrating, and then the hip has dislocated. So in the first stage, everything comes out and a plate goes in. And then in the second stage, you reconstruct it with bone grafting and with further plates and screws. Another case of a traumatic periprosthetic fracture treated in a single stage with double plating. And you can see that I don't know whether you can appreciate this, but from the posterior approach, if your anterior column remains displaced after you've reduced your posterior column and there is still a gap, you can use an anterior column screw. So those who are familiar with pelvic acetabular surgery will know the technique, but you can use an anterior column screw to gain additional stability and then fix it with 2 plates, a trabecular metal cup, and a revision. So this was another complication in the series. This was quite a difficult case with 4 previous revisions, the latest being a failed cage. And you can see that there's a lot of bone loss in the acetabulum. The entire anterior half of the socket, almost from 12 o'clock to 6 o'clock, was missing. So really today, I think the only option in my hands for these cases would be a custom tri-flange, because if half the acetabulum is missing, you can't really put anything into it. But at that time, we attempted reconstruction using bone grafting, plating, and a cemented cup. And obviously you can predict that from day one, this is going to fail because there is no acetabulum left anteriorly. So very rapidly she failed, the plate broke, the discontinuity obviously did not heal, and she developed a non-union and the cup started migrating. By that time she had had 5 operations, and we decided to call it a day, took everything out and left it as a pseudo. Now this was a well-fixed car stem, which is a bigger version of the chorale. And it was so well fixed that to take it out, we would have had to cause a lot of destruction in the femur. So what we decided to do is we just cut the car stem with a Midas Rex, a metal cutting device, and we left it as a girdle stone excision. This was another complication, deep infection. I've shown you one case already. This was another case where I'd been asked to help a colleague who discovered discontinuity during surgery. So this was a constrained cup revision that had been done previously. And when we looked at the preoperative x-rays, you can actually make out that the discontinuity was obvious. Anyway, so this was during surgery, reconstruction with the help of a superior segmental structural head graft, a trabecular metal cup. And because there was also history of recurrent dislocations in the past, we used a constrained version of the liner for the TM shell. Unfortunately, he dislocated despite the constrained liner. And again, the stem had not been revised. So the stem was then revised. But after that, within 6 months, he got quite a bad infection and ended up with a girdle stone excision. So infection risk is also quite high in these cases because many of them have had 4 or 5 or 6 revisions in the past. And you're really reaching into the territory of extreme orthopedics. You know, sometimes I wonder whether these are actually even reconstructible, whether these should be even attempted. Technical aspects, I've shown you some of the techniques already using a Cocker-Langenbeck approach. A good exposure is very important. One of the advantages of doing acetabular surgery is that you get comfortable with big exposures around the pelvis. Remove the components safely. In the vast majority, you can take it out from the Cocker-Langenbeck, but if the component is sitting on a blood vessel, then in the first stage, in the supine position, we get a vascular surgeon, and using either a stopper or a Rutherford-Morris approach, we mobilize the blood vessels, safely take them in slings, remove the cup or mobilize the cup from the inside, then turn the patient over, and then extract the components posteriorly. Then you mobilize your columns and you reduce them. Many times the lower fragment or the inferior portion of the acetabulum is shifted medially, posteriorly, and it is rotated externally. So you have to do an ischial spine osteotomy and mobilize it really well so that you can derotate it and reduce it and then fix it with usually with double plates, but sometimes you don't have that much space and a single plate is necessary. If the posterior superior segment is missing or a piece of column is missing, then I use a structural femoral head bone graft. And nowadays in elderly patients, you have augments that work extremely well. Then you can safely implant a component if stability has been achieved. And I've got a very low threshold of exchanging the stem. So this is how I do bone grafting. If you're doing impaction grafting, a fresh frozen femoral head, which is nicely washed and debrided, the surface, take out all the soft tissues, cut it into slices, and these are handmade chips, which are then packed into a contained defect. How do you contain a defect? You can use an augment. In this case, I've used a femoral head graft. Now, if the head graft is sitting predominantly superiorly, then you can just use 2-3 screws because it is loaded in compression. But in this case, you can see it is replacing most of the posterior column as well. So in that case, additionally, this plate that you use to fix the column can be used to buttress that femoral head bone graft, and some additional screws for rotational control. And then you ream into the bone graft, and effectively you're creating a new socket and you're replacing all the bone that is missing. And then after that, you can put a cemented cup into it or an uncemented cup into it, or whatever is your usual preference. In this case, I've used cement, and you can see it's a solid reconstruction. Complications, I've shown you some cases already. Dislocation risk is high. I've shown you some infections. I've shown you a non-union with failed healing. And obviously there is a risk of nerve and blood vessel injury. In my series, I have at least one patient who has a complete dense sciatic nerve palsy, which did not recover, and one who had a partial, which recovered. There was one case in my series of a minor vascular injury, and that's more probably because routinely I get CT angiogram and the vascular surgeon will come and help if the cup is intrapelvic. So I suppose we have managed to mitigate the risk of vascular injury by using that strategy. So that was the first philosophy, and one of the commonest ones that I implement in my practice, which is fixation with plate, bone grafting, and then using the trabecular metal shells in 1 or 2 stages. The second philosophy, which is also quite popular, is the cup cage construct. And I'm sure all of you know about Paprosky's work on stiff discontinuities and using the distraction technique. So what you do is you put a cup that is bigger than the size of the discontinuity. And if the discontinuity is quite stiff, then it slightly stretches out and gets inherent stability. I've not gone along this line because intuitively it doesn't really make sense to me, because for me a discontinuity is a non-union, and then I'm making my non-union worse by increasing the gap. But it's a well-recognized technique, and Dr. Paprosky has published his results on this for more than 10 years now. What you can additionally do is convert it into a cage as well. So the cup is first put into the acetabulum with multiple screws, and then the cage goes on top of the cup using additional screws to fix to the ilium and to the ischium, and then you can use a cemented cup. So what the cage does is it protects the cup until it has ingrown. And this is a case where we have used a cup cage construct. You can see this is an intrapelvic discontinuity. It was one of my colleagues' cases. And what we have done is bone grafting, TM shell. There's an additional plate as well at the back because we were not 100% confident that the cage will do the job that we want it to do. And I've said before that I feel that tension band plating or convex plating is biomechanically much stronger than concave plating, but she did quite well with that technique. And then finally, the third philosophy that we implement is the custom prosthesis. So we have done quite a few of these as well for pelvic discontinuity. You can also use these without discontinuity when there is very significant bone loss that is not reconstructible with something that you have on the shelf. So whatever prosthesis you have on the shelf, it might be jumbo cups with plates. And if you cannot reconstruct it because there is very little bone remaining, then we would go for a custom prosthesis. We would try and avoid a custom prosthesis in young people because once this fails, there is very little to go to after that. So we prefer to use it in older and low demand patients for segmental or gap discontinuities and for mobile discontinuities where you can't get stability quickly. One of the advantages of custom components is that it comes with some very good planning software. You get fine slice CT scans, and then you build this 3D PDF model which you can rotate on your screen. You can play with it. You can change the density. You can make it transparent. You can move the component around, and you can see that, you can assess the bone stock quite well, see how the component will fit. Then you can make changes to the component. You can make the flange a little bit more posterior, a little bit more anterior. You can change the direction of the screws. You can add a third flange. One of the things that we added as pelvic surgeons is we like our anterior column screw to go into the superior pubic ramus, or the anterior column. And we started modifying the original design by using these additional screws. So this is how it comes. You get your pelvic model on a PDF. You can play with it. You can assess the bone loss. And it gives you this heat map. So this is based on the CT scans. And what it does is it colors the pelvis based on how much bone is remaining. So the green color is good bone or excellent bone. And that is where you tend to position the screws. And all the red and the orange or the bone is the poor quality bone that is usually of no supportive value. And in between that, you get some acceptable quality bone. And this is excellent really in planning. And again, this shows how you can plan your screw trajectories. You can put multiple screws. You can change the hole, the angles, and that long green screw, you can see how it can go into the anterior column. You can plan the length of the screw. And when the final implant comes, it comes labeled with each screw and each screw length. So you know precisely what you're going to do. So a lot of planning is involved. And the more time you spend in planning, the less time you spend in surgery. So this was an elderly patient with very severe bone loss and adverse reaction to metallic debris because of metal-on-metal failure. And I'm sure those of you who have revised ARMD cases will know how significant the destruction of the bone is. So in the first stage, I took everything out and just left him as a girdle stone. Then we planned for a triflange. And in the second stage, we have done a triflange, and he will probably come up to about 6 years now with follow-up. So it does, the device does very well in low demand and elderly patients. This is another example of a gap discontinuity that was managed with the first stage excision and then planning for a custom. And then that's the second stage with a custom acetabular component. So the shape of the custom will basically depend on the shape of the bone loss. And they can change the shape and they can modify it. You can make the undersurface of the cup porous coated as well, if you think it is going to come into contact with bone, so as to get some ingrowth. The short-term fixation is based on the screws, and theoretically the long-term fixation should really be based on ingrowth of the rough surface against whatever host bone is available. Whether or not that happens is debatable, but that's the theory at least. Another few cases where we've used custom components to reconstruct the acetabulum, and this was an intrapelvic cup treated again in 2 stages with a custom component. We have published our results of custom. It was published only very recently, I think a few months ago, our first 2021 cases. So we're doing about 6 to 8 of these in a year now. And we've also reported our data on discontinuity work, on periprosthetic fractures as book chapters and as articles. So what have I learned in the last 15 years about discontinuity? For me, it is an acetabular non-union. And the first strategy I would try and use is to fix the non-union with stable column plating with bone grafting. Get the non-union to heal. Once the discontinuity heals, you have given bone back to the pelvis, and you have bought for your patient many years worth of hip life, so that even if your revision fails, you've actually given back bone for the next revision. Depending on how stable the fixation is, you can reconstruct it in 1 stage or 2 stages. Nowadays, if I'm doing a 1-stage reconstruction, I will avoid a cemented cup. I will go straight to a trabecular metal fixation. In 2 stages, both will work extremely well, cemented cups as well as trabecular metal cups. So I'll do whatever is easier on the table. For stiff discontinuities, just a single stage T-Mars cup as determined by Paprosky or the cup cage construct can be used. But for mobile discontinuities, it is very difficult to achieve distraction because everything is just mobile and flopping about. So in these cases, you have to make it stiff by plating the columns and then carry on with the reconstruction. In segmental or gap discontinuities, or where the bone loss is very severe, we go for a triflange custom component. And there are 2 or 3 companies that supply to us. Each of them has their pros and cons. The most important message to take home is when you're doing lots and lots of primaries, and I know that thousands and thousands of primaries are being done in India, it is important to follow up the patient on a very regular basis. So some sort of a follow-up regime, let's say 1 year, 2 years, 5 years, 8 years, 10 years, and then 2 yearly after that is very important, because if the cup is going to fail, you have to pick it up at an early stage and revise it before it develops into a discontinuity. If you pick it up early, a simple revision might do the job, where if it is left festering, you're going to have a lot more difficult revision in your hand. In terms of these philosophies, there are quite a few well-accepted philosophies now. What is important over the long term is to keep following up these patients that we have done and try and define the indications even more accurately. When will you use a cup cage? When will you use a tri-flange? At the moment, I think a lot of this is decided based on surgeon preference, surgeon training, and availability. And hopefully with long-term follow-up, we will be able to answer some of these unanswered questions. So I like this term, joint at the hip, which I coined up about 10 years ago when I gave my first national talk on discontinuity. And what I wanted to convey is this is one part of revision surgery where the acetabular surgeon and the revision hip surgeon are joined at the hip, literally because you're joining it at the hip, and figuratively because you're working together to solve these difficult problems. And I always recommend for our fellows who want to do complex revision surgery to go and spend 6 months or 1 year in learning pelvic and acetabular surgery to gain that kind of experience. Thank you.
Excellent, Nikhil. Thank you very much. It was very crisp, very clear, and you gave us good illustrative cases and the reason behind the philosophies and the execution. So I congratulate you for this excellent work, and I thank you for sharing it with us and for your time and for your preparation. Thank you very much.
My pleasure, Kiran. Thank you.
So I'll leave it open to the panel, and in our panel, I admit I don't have much experience in this kind of work, but Dr. Vikas is very experienced, and I would definitely welcome his thoughts, and also Gurinder, and if Narinder has joined us, and Surendra also. So the panel can contribute now, and we can go back to the PowerPoint and ask for the cases to be discussed if needed. So who's ready with any points or questions? Okay, Gurinder, unmute yourself, please. Unmute yourself. Yeah.
Hi, Nikhil. Wonderful collection. I think it just puts me into depression watching you guys go with these kind of cases. I mean, it's absolutely fantastic. The problem is, one, I don't think I have the talent enough. Second, I don't know when I'm going to find these cases. And I know it's like it's exhaustive on your heart to keep doing these kind of things. It just decreases your lifespan by a few months every time you do this, and the loss of hair as you.
That's why
it's very exhaustive. I mean, you go back at the end of the day, and you spend your 3 to 4 hours, and the worst thing is, the first check X-ray which comes, and you say, oh, it's dislocated, and you really know what I mean. I did my best I could, and you have to go back again and sort it out, because the chances that it's going to stay in, despite you having to doing everything, is going to be. So is that the first X-ray that you're going to see is if that doesn't look good, you really had it. Do I take it all of these guys? You put a C-arm anyway, just to have a look about where things are with this?
No, I've had this traditional bias against bringing a C-arm in the operating field when I'm doing arthroplasty. It may be wrong, and I'm sure that people are doing it very well, but I just worry about loss of control on the territory.
It does happen.
When I'm operating on my revision with my team in the pod, I don't want any interference with external objects coming in. But what we do at Wrightington is we do a recovery X-ray. So as soon as the patient is off the table, he gets a supine X-ray in the recovery, and we always watch the X-ray. And if there is a problem, sometimes you do discover that the hip is dislocated. If there is time left on theater, we try and correct a day one problem. one of the most famous sentences I have ever heard when I was doing my MS in India was from Dr. Tanna in Mumbai. And he used to show these fracture fixation cases, and he used to call them as day zero failure. And if you have a day zero failure, it is not going to get better on its own. You have to rectify it.
Quite right.
So yes, that's right.
Okay.
In terms of the difficulties, yes, you're right. They're physically demanding, they're mentally demanding. And that's why I feel you have to do it with a good team. I work with some fantastic colleague consultants. There's almost 14 hip surgeons in the unit. All these cases get discussed. There's only 2 of us who mainly do discontinuity, myself and my colleague Henry Wynne Jones. And almost all of these cases get discussed. We tend to operate together side by side so that if one of us needs help, the other one can scrub in. And yeah, that's how we do it.
Tell me about in your mind, the trend more and more is less plating and more cup cage construct coming up now. I think the plating would have gone down substantially, wouldn't they?
It's interesting. I think people who are not pelvic and acetabular trained, they feel that a cup cage will get them out of these difficult cases. And I think sometimes it will. But even that, we have seen it fail. We have a separate group in India called AUPAS. I don't know whether you know about it. Association of Pelvic and Acetabular Surgeons. Yeah. And we often discuss cases on that group. And in fact, just 2 weeks ago, we were discussing these discontinuity cases. Surprisingly, all my pelvic and acetabular colleagues agreed that their first choice is to fix the discontinuity and then implant the cup. So I guess we tend to do that more commonly.
And I think the arthroplasty surgeons are much more likely to put a cup cage kind of a construct.
Go to a cup cage, yeah.
Tell me about this tension band plate that you're talking about. I haven't got the gist of it. So you're putting a plate along.
It's a concept. I was trying to explain a concept. When you do your femur plating, you put the plate on the convex surface of the femur, which is the tension surface, so that you get very good compression on the concave surface.
Yes.
If you put a medial plate on the femur, it is very unlikely to succeed. It's probably going to fail because the biomechanics is not right.
Not right.
So think of the acetabulum just conceptually as a concave surface, which is the inside of the acetabulum, and a convex surface, which is the posterior column. Okay. A cage, what does a cage do? A cage is an internal plate, isn't it? You put it inside the acetabulum, and then on those flimsy flanges, you put some screws in the ilium, and you try and put some screws in the ischium. And many people actually break off the pubic flange if it is still there, and they use 2 flanges. Or sometimes there's a hook, and you put the hook inside the obturator foramen, and then you just put the iliac flange. So then there are no screws at all in the lower fragment. For me, that is biomechanically not very good to stabilize your discontinuity. That's not how you would fix any other fracture. Conceptually, if you put 2 plates on the posterior column, which is the convex surface of the acetabulum, you can compare it to the tension band principle. Okay. How do you fix an acetabulum fracture? You put 2 plates at the back or 1 plate at the back, depending on whether it's transverse or transverse posterior wall or associated both column or whatever it might be. And then if the anterior part is still gapping, you put an anterior column screw under vision. And that's how you get solid stability to mobilize the patient. So if you fix a discontinuity also in that way, on table, I can tell you, putting 2 plates gives you so much stability that when you put your trabecular metal cup in and you impact your cup, you get rock solid primary stability, and you almost feel, I don't even need screws in this. But obviously, always put lots and lots of screws, inferiorly, superiorly, and anteriorly if possible. But that kind of stability you get with a double plating. You just cannot get that feeling with a cage. Try it on a cadaver. Next time you have a cadaveric workshop, try it.
Okay. Tell me, when you, for ischial fixation, in your opinion, what's a better option? You make a slot and you put the fin in, or you try to put screws into the, I'm not talking about a plate, I'm talking about a cage kind of a thing. Would you rather make a slot and put the fin in, or would you rather put screws in it? What do you think gives you better hold?
I don't use cages that way because like I said, my experience with cages has been inheriting failed cages and revising them. So again, this is where bias creeps in. So I don't do cages at all. I've seen both types being used, and for the skilled surgeon, I don't think it makes a difference so long as you get good fixation at the bottom. If your bone stock is good, I think screws work better. If the bone stock is poor, you probably want to use that slot so that you get at least some fixation. But I've seen both types of cages pull off the inferior bit and start walking away superiorly, like those two X-rays that I showed. That happens almost always. That happens. That's how a cage fails.
That's because of biomechanical, concepts like you explained probably, and the poor bone
Again,
quality.
my
Poor
gut
bone
feeling
quality
is
as
that
well.
when a cage works really well, 7, 8 years, 9 years follow-up, sometimes you do see cages that work really well. But if you look at those X-rays, I wonder whether a cage was required in the first place. And when you really, really, really need the cage to work, somehow it fails at 5 to 7 years, or even earlier than that.
So, Vikas?
Nikhil, very nice presentation, and you covered almost the complete spectrum. I'd like to just add or share our experiences of discontinuities. So, by and large, we have done a fair bit of them in our tertiary referral center in Delhi, and we still keep getting a few, but main volume goes to our Army Hospital RNR. So when we were working there, we reviewed these cases, and we realized what was our experience was mainly these cases fall into 3 groups, as you rightly brought out. There was acute discontinuity, which came in where a primary surgeon had reamed out, and we had an acute fracture kind of situation, which was brought in for a redo. Then there was a group which was subtle discontinuity, which happened over a period of time, and these were more difficult to handle, and these were cemented revisions. And there was another group which was late, but kind of acute on chronic, where it was heading for a poor bone stock and then had an acute fracture. So these were by and large the groups. Our experience was that in acute setting, when we use the chronic principle, we failed. So these cages really failed miserably in acute situations, and we actually had to go leave these patients alone and come back later to redo them. And this is where we realized that in acute setting, we need to treat them as fractures. So acute settings, we revised our strategy to plating, grafting, and really being very sure that this cup has a base, or we really left and came back like you had done. You showed few cases, and that's what our strategy was in acute. And when we used a cage in such an acute setting, a cage failed. In the chronic ones, our experience was that if you very carefully analyze them with CT scans, wherever the ischial bone stock is going bad, these were the ones which were tending towards discontinuity. Apart from the fact that they also had poor ischial bone, and that was the difficulty in handling them with a jumbo cup also at times, and they needed a cage or some kind of cup cage construct to protect it more. So one thing to be careful is when you go in for these discontinuities, you just can't go in with one strategy. You need to think about whether you will be able to handle them with a plate, with a jumbo cup, or with a cup cage. You need to keep all in your shelf. You can't decide that, okay, I'm going in, this is a fibrotic non-union, and I will just distract it and get away with it. We have faced it that we thought that this one is old, chronic, fibrous, and we will distract with the jumbo cup and get our fixation and come out, and we couldn't. And it keeps just going away. It keeps expanding. So at times you need a plate, you need and it is terrible to see on the table where you always feel that I just cannot offer anything else to this patient and I might just have to come out. And that is when you have to have your line drawn. This is discontinuity which cannot be distracted. And this is something which you come to know on table. And it's very difficult to preoperatively assess these patients. You will get a very flat acetabulum. You are trying to create a socket there, and then you're trying to distract, and your distraction is just not giving you the stability. And this is where you should stop trying that, and you should go back to either plating, grafting, and then deciding whether you want to do it now or later, or you need to go to a cup cage construct. Our experience has been fairly good with a cup cage construct, but in all these cases, we realized, as Nikhil pointed out, that the cage was just supplementary. It was not really the prime a prime stability factor there. It was more of an augment, and where it was needed as a plate also, it didn't do very well. So we added a posterior plate to it, like Nikhil had done. So under continuity is a continuum, and there are no specific indication that this or that. You may need all of them, and you may need to be prepared for all of them. Doing a pre-op careful assessment, especially looking at the ischial bone loss, the fracture line, the possibility of it being mobile discontinuity is very high. And just thinking that I will get away with a jumbo cup is a wrong idea, which we burnt our fingers at times, and we realized that we need to be aware of this. So difficult, challenging, but doable. And as Nikhil pointed out, if you keep these thoughts in your mind, and of course, most of us in army are pelvic background. So we have done trauma. And so for us, plating is just comes naturally. So if we, in fact, it's the other way around, that we first would like to plate, then do the hip, rather than doing the hip and thinking of a plate. So having that outlook helps you, because we like to fix first and then work on the cup. So that was.
Yeah, well pointed out. If Narinder, do you have any points to make, or any questions or any comments?
We just joined in late. I'm just listening in.
Okay, so Nikhil, when it comes to the chronic ones, and where you go for the custom tri-flange ones, do you also have the model sterilized and kept on the table so that you can actually play around in real time to get more information? Do you do that?
Yes. So what they do is they give you one pelvic model and they give you one non-sterilizable tri-flange sort of like a trial prosthesis, and you can play with that before you scrub up, and that always is there on the side. You can look at it. And then they give one sterilizable transparent, I don't know what material they make it from, but it's transparent and it's sterilizable. And once you have done your exposure, you take the model, you put it in the acetabulum, you check that it's fitting. Sometimes you have to do some minor adjustments with a little bit of burring of bone here or there, and so that it fits in exactly the way that it fit in your non-sterilizable model. Once you're happy with it, then there is a sequence of the screws, and the screws are all labeled, some say 1 to 20 or whatever. And then you put your screw number 1, which is 45, your screw number 3, that is 65, and you just keep filling up with the screws until you get a solid construct. You can put bone graft in addition. And then majority of the cases, these tri-flanges, nowadays we design them with a dual mobility insert. So then you can cement a dual mobility insert inside that, and then you deal with your stem in whatever way you want to. It takes usually between 3.5 to 4 hours to do. The most difficult part I always find is the exposure. And you mentioned this stiff discontinuity. If I'm a little bit skeptical, for me, a stiff discontinuity is something you haven't exposed properly. So the fibrous tissue is still there. Once you take out the fibrous membrane inside the acetabulum, the stiff discontinuity doesn't remain stiff anyway. And unless you take that fibrous membrane out, you cannot expose your host bone either for bone grafting or for ingrowth. The second problem is many of these stiff discontinuities actually go into a malunion. So your lower fragment rotates. And when you go and look at it, it looks as if the posterior column has disappeared. And you have to appreciate that malalignment, osteotomize the ischial spine and derotate it. And to do that, you have to again excise all the fibrous tissue. And once you do that, it becomes mobile again. So I have to say, I struggle to find a stiff discontinuity because by the time I've done the exposure, they're all mobile.
You redefine.
I just wanted to add one. Dr. Gurinder asked that about the ischial flange. We, in Indian bones, we have not been, we tried in 1 or 2 cases, but that slot, getting it at the right place and then trying to get a bone stock for it is not easy. So we used the hook ones, and we realized that wherever actually you need to bridge with a cage using it as a plate, it is difficult. So it can offload the dome. So it's better to plate and offload the dome with the cage rather than using the cage as a plate, because we are not able to get a lower fixation with the cage very well.
So that's what I was saying, that instead of a cup cage construct, you go to a cup plate construct. The plate works much better than a cage, and then a cup does what the cup is meant to do.
I just wanted to comment that the ischial hooks have not been a problem personally for me. Maybe I'm a little different. Maybe I'm doing some things in a different way. Ischial hook has never been a problem, putting in an ischial hook.
Cup cage, and a cup cage scenario, not a pure cage scenario.
Yeah.
In a cup cage, to get at the right slot with that edge into retroversion of the cup.
If the ischium is there, you should be able to get it in there. But anyway, I guess
the bone stock is very poor and it gets damaged. So we have not been using that slot for it. Yes, what you would do is, if you're not using a TM cup, you're just going for a graft and cage, then it is possible. Then it's easier. I'm not saying it's not possible. Cup cage has been designed to work like that, to put a cup TM in retroversion and then put the cage flange there. But if the cup is not properly retroverted, that part doesn't even get exposed, that where the ischial flange has to go. So that is a difficulty which we have faced. I don't know.
Nikhil,
size is a problem as well. You can't use the cup cage in small patients. Even the smallest one only fits for reasonably big defects, big patients. So we get quite a few small size patients who come with discontinuity, and even the smallest cage of the cup cage will not fit in them.
I think we've had the same problem. The cage is the only cage that actually I've ever used are the small size. We've never been able to put anything more than a small size for them. So tell me, Nikhil, about these, the cup in the pelvis scenario. Is it true to say that majority of the acute ones you'll be able to pull back? Because, it's a fairly common scenario, finding somebody who's knocked it inside, or, having done it myself, I thought it was a stupid thing that I did myself. So, you got that cup lying inside, or the bipolar, which is just gone inside in an acute setting. Majority of the time, I've always gone with, I can say I've count on my tip of my fingers the numbers that I would have done. Majority of the time, it does come out, doesn't it? And what's the trick to that, to understand that, one of them is going to get caught out sometimes? Acute setting.
Yeah. I've got a collection of intrapelvic cups, and it's a separate talk that I give in our Writington Revision Arthroplasty Symposium. But yes, you're right. If it happens on table in front of your eyes and your cup falls in the pelvis, then obviously you've reamed it. So long as you haven't reamed through the iliac blood vessels, it is quite safe to gently take it out. What happens is the intrapelvic cups that I've gone into have already been done, and they've either slowly migrated or they've migrated acutely, but in some other hospital. So it's very difficult for me to predict where the cup will lie. And so I routinely get a CT angio done if it's a referred patient. And then based on that, we make a plan whether the vascular surgeon is going to be required to scrub, whether he's just going to be required to be around somewhere in the hospital for me to phone if required, or whether he does not need to be in the hospital. And then when I mobilize the cup, I always do. Sorry?
From the you're going to, majority of the time, you will always attempt to go from the established side, right? From the
so we have a regional vascular orthopedic MDT, and they will advise us that this is quite safe. The blood vessels are nowhere nearby, and there is a good clean plane, and you can take it out by your usual methods from the hip joint. And then I do a Cocker-Langen back. If you put your finger behind the quadrilateral plate through the greater sciatic notch, you can mobilize the cup and then gently tease it out. Otherwise, or they'll tell us that if there's an infection in association with an intrapelvic cup, then it's a very dangerous scenario, because you just don't know how dense the infective pseudomass is. And in those cases, if you try and take the cup out, you're likely to have a major vascular injury. So then we prefer the vascular surgeon, and we go intrapelvic first, safely mobilize and isolate the blood vessels, then come out again, hold the blood vessels in the sling, drape it, take the cup out, take everything out. And in those cases, I always do it in 2 stages. I would not attempt those in a single stage ever.
But in a non-infected scenario, you would not have, if it is not obstructing anything.
In the non-infected scenario also, if I have to open the pelvis on that day and mobilize the blood vessels, I will try and not do it in 1 stage.
But do you have to remove it always? You could leave it. inside?
You don't have to always remove it. And I think last time I showed a case in the infection conclave where I had not taken a case out, a cup out, because it was felt it was not necessary. She got infected after 2 years. If it's safe to take it out, I would prefer to take it out, because what you think is non-infected could be infected.
Nikhil, this is very excellent talk, and really, like, cases which you can think of, only we can dream of. My question to you is, like, do you always do a posterior plating, or at times you need to go down and do the anterior plating as well for getting the good stability of the two columns, or the proximal and the superior and the inferior innominate parts?
Right. So in discontinuity cases, we have never done anterior plating because, again, our group believes that your iliopectineal fascia does form a physical barrier between the pelvis and the hip joint. And we have seen cases of intra-abdominal sepsis secondarily infecting the hip when that barrier is disrupted. So the second reason we don't do it is because with the double plating at the back and using an anterior column screw if required, you can get very, very good stability so that an anterior plate is not required at all. In the acute scenario of periprosthetic fractures also, or when you're doing a fix and replace, in the vast majority, we will use a single posterior approach, double plating, anterior column screw, and reconstruction. There are some fix and replace cases in an acute acerebellum fracture where it is so comminuted that you cannot not go anteriorly. You have to do a stopper, fix it anteriorly, and then come back, fix it posteriorly, like the A-frame concept.
Mm-hmm.
Probably in our unit, we are a bit more conservative for those cases. And when it is that shattered that you need to do a front and a back approach and a total hip, a total of 5-6 hours of operating, many of them we will treat conservatively, let the anterior column heal up, let the posterior column heal up as best as possible, and then do a fairly straightforward hip replacement at maybe 3 months or 4 months. And the patient can be mobile in that time using crutches. So I've avoided doing an anterior plate and a posterior plate and a total hip at the same sitting, probably because of inheriting quite a few cases of infection when that philosophy was used. I'm sure there are other surgeons who do that very successfully.
Right. Thank you.
Any other points, gentlemen? So I think with this, Nikhil, I would like to thank you once again for your time and showing us, a spectrum of cases. And, it was really enlightening, and it's a very challenging scenario. And as you said, if you take help, then, we mere mortals should definitely consider it, especially for these challenging cases. The message is not to attempt this, on your own. Really plan it well, and really, spend that time to choose your implant and construct. So I think with this, I will, close this webinar and thank Nikhil once again and the panel for joining in. And thank you, Ashok and Neeraj. Yes, thank you very much, OrthoTV.
Thank you.
Thanks, everyone.
Thank you. Bye-bye.
Bye.
So Neeraj is there. Thank you, Neeraj. We can end this conclave.
Neeraj is not there, I suppose. He's still online?
Yeah, I can see it's live. So I think maybe we can leave the meeting.
Yeah, I think we need to move.
Yeah, we can do that.
Okay. Thank you, everybody.
Thank you, Kiran.
Thanks. Bye.
Bye.